Welcome to the Deep Dive, where we help you ace the FRCS plastic surgery exam.
That's right.
And today, we're going to be tackling a topic that is guaranteed to show up on the exam, and that's distal radius fractures.
Yeah. Distal radius fractures, really common, and you need to be ready for anything they throw at you,
Oh, for sure, for sure.
from presentations and classifications to management and complications.
So let's get started with the basics then.
Sure.
Just how common are these fractures?
Distal radius fractures, they make up a whopping 1/6 of all the fractures that are seen in emergency rooms.
Wow.
That's over 640,000 cases annually in the U.S. alone.
Oh, wow, that's a huge number.
It is.
I guess that classic Fuhegich fall on an outstretched hand
Yep.
is a pretty frequent occurrence.
It is. It is especially in women over 60, often due to osteoporosis.
Right.
Younger men, though, are more likely to get these fractures through high-impact events like sports injuries.
Okay, makes sense. So to properly manage these fractures,
Yeah.
we need to have a good grasp of the anatomy. What are the key anatomical features of the distal radius that we should be aware of?
Well, the distal radius has this really unique shape
Okay.
that really dictates how it fractures.
Uh-huh.
The dorsal side, think the back of your hand is concave and thin,
Right.
making it very vulnerable to comminution.
Okay.
Whereas the volar side, the palm side, is convex and has thicker bone for strength.
Interesting. So the dorsal side is more likely to kind of shatter, whereas the volar side's a bit more robust.
Yeah, you got it.
Are there any other important anatomical landmarks that we should be aware of?
Absolutely. So, for example, the brachioradialis
Okay.
is the only tendon that directly inserts onto the distal radius.
Right.
Then you have those three columns of the distal radius, the radial, intermediate, and ulnar.
Uh-huh.
These columns are super important for understanding fracture patterns and stability.
Right. Those columns come up a lot in the classification systems. What about the intra-articular anatomy?
Yeah,
Things get pretty complex in there.
they do. You've got the scaphoid and lunate facets, which articulate with the carpal bones.
Right.
Then there's the sigmoid notch for the ulna and the TFCC, or triangular fibrocartilage complex,
Okay.
which is essential for stability at the DRUJ, or the distal radial lunar joint.
Mm-hmm.
Oh, and don't forget those volar ligaments.
Yeah.
They're much stronger than their dorsal counterparts and provide really crucial support.
Okay, so we've got these three columns, multiple articular surfaces ligaments. TFCC, it sounds like a recipe for a lot of different fracture patterns.
It is, and that's where those eponyms come in.
Right.
Kalsa-Smith's, Barton's, die punch, and chauffeur's fractures.
Yes.
Each one has a distinct pattern you need to be able to recognize.
Absolutely. So like Call being that classic dinner fork deformity.
Exactly.
What about Smith's?
Think of a Smith's fracture as the opposite of a Call's fracture.
Okay.
The distal fragment is displaced volarly instead of dorsally.
Okay, got it.
Then there's Barton's, which is basically a fracture dislocation, where the carpus and a piece of that articular surface kind of sublux.
Uh-huh. And a die punch fracture involves a lunate facet, right?
Exactly. It creates a depression in the lunate facet, awfully from a high energy impact.
Okay.
And lastly, you have chauffeur's fractures, which are isolated fractures of the radial styloid process.
Wow. Okay, that's a lot of different fracture types to keep straight. It's no wonder there are so many classification systems for distal radius fractures.
You're telling me we got Mayo, Freichman, Maloney, AO,
Yeah.
the list goes on.
So which one should we focus on for the FRCS exam?
Well, none of them are perfect in terms of inter-observer reliability,
Right.
but for the exam, the Mayo classification is a good starting point.
All right.
It categorizes fractures as extra-articular or intra-articular based on their involvement of the radiocarpal joint.
Okay, that seems simple enough. How does the Freichman classification differ from Mayo?
Freichman takes it a step further by considering both the radiocarpal and radial ulnar joints,
Okay.
as well as the presence or absence of an ulnar styloid fracture.
So more details, more complex.
Pretty much.
Got it.
Yeah.
But before we get bogged down in classifications, let's talk about how we actually approach a patient with a suspected distal radius fracture.
Sure.
What are some of the key things that we need to think about when we're taking their history?
The history is crucial.
Okay.
You want to know their age,
Yeah.
dominant hand occupation, their medical history, and of course, how and when the injury happened.
Right, because that information helps paint the clinical picture and helps us guide our management decisions. What about on physical exam?
Right.
What are the key things we need to assess?
Well, neurovascular status is paramount, especially the median nerve.
Okay.
You're also looking for any associated injuries to the wrist forearm and even the elbow.
Right, so we're not just focusing on the fracture itself, but also assessing for any potential complications.
Exactly.
What about the carpus?
Don't forget to palpate the carpus for any tenderness and assess for intercarpal ligament instability.
Okay.
And of course, you always want to examine the DRUJ for stability.
Right.
A positive fovea sign could point to a TFCC tear.
Speaking of things we don't want to miss,
Yeah.
what about carpal tunnel syndrome and scapulinate ligament injuries?
Excellent point. Carpal tunnel syndrome can occur in up to 8% of distal radius fractures.
Wow.
And scapulinate ligament injuries are even more frequent, especially with those intra-articular fractures.
Okay.
And while it's rare, compartment syndrome is a surgical emergency that we absolutely cannot miss.
Right, absolutely.
Hmm.
So we've taken a thorough history, performed a meticulous physical exam, and now it's time for imaging.
Yep.
X-rays are our go-to, right?
Absolutely. Standard PA lateral and a modified lateral to really scrutinize that articular surface.
Right.
A traction view can also be helpful to assess comminution and articular involvement.
Okay.
And remember, always image the joints above and below to rule out any additional injuries.
Makes sense.
Mm-hmm.
But it's not just about identifying the fracture, right?
Right.
There are all those important radiographic parameters that we need to assess as well.
Mm-hmm.
What are some of the key ones?
Articular step-off is a major predictor of outcome. Even just 1 millimeter can lead to long-term problems.
Yeah.
Then you've got radial height, volar tilt, and radial inclination. Knowing their normal values and how alterations can impact wrist mechanics is crucial.
Right. Those parameters tell us how well the wrist is aligned and whether or not it's likely to function properly.
Exactly.
What about the teardrop angle?
The teardrop angle helps us assess for articular incongruity within the lunate facet.
Okay.
And don't forget the rule of 11s to help you quickly recall those critical parameters.
Yes. Mnemonics are lifesavers in the FRCS exam.
For sure.
But enough with the measurements.
Yeah.
Let's talk treatment. How do we decide when to operate versus when to go with conservative management?
Right. Well, that's where the OUR-MS acronym comes in.
Fair.
Articular congruity.
Okay.
Radial alignment and length, motion, and stability.
Okay.
These are the goals we're aiming for when treating these fractures.
So it's not just about fixing the broken bone, but restoring the biomechanics of the wrist as a whole.
Exactly. Now, for non-displaced extra-articular fractures, closed reduction and casting is usually sufficient.
Okay.
Even with some displaced fractures, it's worth attempting closed reduction, especially in older patients.
Right, but close follow-up with repeat x-rays is essential to make sure things stay in place.
Absolutely.
Now, there are certain situations where surgery is definitely indicated.
Yes.
So what are those?
For example, if radial shortening exceeds 3 millimeters,
Okay.
dorsal tilt is greater than 10 degrees,
Uh-huh.
or there's intra-articular displacement or step-off greater than 2 millimeters.
Got it. So those are red flags for surgical intervention. What are our surgical options?
Well, it depends on the fracture pattern and the patient's individual needs.
Okay.
We have percutaneous pinning external fixation, fragment-specific fixation, and ORIF, often with volar plating.
Okay, so a whole range of options. Volar plating seems to be the go-to these days. What are its advantages?
It provides better visualization of the fracture, a more stable construct, and it allows for earlier mobilization.
Okay.
We often use bone grafting or substitutes to fill metaphyseal defects and enhance stability.
Right. Especially in comminuted fractures.
Right. Restoring that radial length is key. And after fixing the radius, we can't forget about the TFCC.
Absolutely. We always assess DRUJ stability intraoperatively with the piano P test.
Right.
Instability suggests a TFCC tear, which needs to be addressed based on the presence of an ulnar styloid fracture and the severity of the instability.
Good point.
Hmm.
Now, are there any special considerations when managing distal radius fractures in specific patient populations?
Definitely pediatric fractures are managed quite differently,
Okay.
with an emphasis on avoiding plating.
Right.
And in elderly patients, we can often be a bit more conservative,
Right.
as they can tolerate greater degrees of malunion without significant functional impairment.
So it's all about tailoring our approach to the individual patient.
Precisely.
Hmm.
Once the fracture is stabilized, whether it's with surgery or casting, early mobilization is key for optimal functional recovery.
Great. So far, we've covered the basics, anatomy classifications, and even touched upon treatment. What's next? Well, we can't forget about the potential complications that can arise from these fractures.
Oh, right, of course.
We'll dive into those next.
Okay, sounds good. All right, so we've covered a lot of ground already, from the anatomy of the distal radius to the various classification systems and treatment options. But as you know, no surgical procedure is without its risks. What are some of the potential complications we need to be aware of when managing distal radius fractures?
You're absolutely right. Complications can occur, and we need to be vigilant in identifying and addressing them. Let's start with some of the early complications that can arise.
Okay, so what are the things we need to be on the lookout for in the immediate postoperative period?
Well, first and foremost, we need to make sure we haven't missed any associated injuries. Things like scapholunate ligament tears or TFCC injuries can sometimes be subtle and overlooked during the initial evaluation.
That makes sense. It's easy to get focused on the obvious fracture and miss those less obvious but equally important injuries.
Right.
What else should we be watching for?
Another early complication is loss of reduction. We've talked about how important it is to restore radial length and alignment. And sometimes, despite our best efforts, the fracture can shift or collapse after we've set it.
So close follow-up with repeat x-rays is crucial to catch any loss of reduction early on.
Exactly.
What about infection that's always a concern with any surgery?
Absolutely. Infection is a risk with any surgical procedure, and distal radius fracture surgery is no exception. We need to be meticulous with our sterile technique and provide appropriate antibiotic prophylaxis to minimize the risk of infection.
Okay, so we've covered missed injuries, loss of reduction, and infection. What about nerve or vessel damage? Those seem like pretty serious complications.
The median nerve is particularly vulnerable in distal radius fractures, and iatrogenic injury can occur during surgery. We need to be extremely careful when dissecting and placing our implants to avoid any damage to surrounding structures.
Right, knowing the anatomy inside and out is crucial to prevent those kinds of complications.
Absolutely.
What about compartment syndrome? We mentioned it earlier as a potential emergency.
Compartment syndrome is a rare but serious complication that can occur after a distal radius fracture, particularly in high-energy injuries. It's essential to recognize the signs and symptoms early on, things like increasing pain, swelling, and neurovascular compromise.
And if we suspect compartment syndrome, immediate fasciotomy is needed to relieve the pressure.
Absolutely. Delaying treatment can lead to permanent muscle and nerve damage, so high suspicion and prompt intervention are key now, moving beyond the immediate postoperative period. What are some of the later complications that can develop?
Okay, so what are the long-term challenges we might encounter?
Well, one of the most common late complications is malunion. This is when the fracture heals in a less than ideal position, leading to altered wrist mechanics and potential functional limitations.
And I imagine malunion can be especially problematic if it affects the articular surface, leading to joint incongruity and arthritis down the line.
Exactly. Then there's non-union, which is when the fracture fails to heal altogether. This can be a frustrating complication for both the patient and the surgeon, often requiring additional surgery to achieve bony union.
So malunion is when it heals in the wrong position, and non-union is when it doesn't heal at all. Got it. What about pain? I imagine chronic pain can be a significant issue for some patients.
Chronic pain can develop after a distal radius fracture for a variety of reasons, from nerve damage to joint stiffness to tendon problems.
Speaking of tendon problems, we mentioned earlier that extensor pollicis longus tendon rupture is a potential complication. Why is that?
The EPL tendon runs a rather tortuous course around the distal radius, making it susceptible to attrition and rupture, especially if there's any hardware in the area.
An EPL rupture can really impact hand function, especially the ability to extend the thumb.
It can.
What about joint stiffness? That seems like a common issue after a wrist fracture.
It is. Joint stiffness can develop from prolonged immobilization, scarring around the joint, or even arthritis. Early mobilization and a dedicated rehabilitation program are crucial to prevent and address stiffness.
Okay, so joint stiffness can limit wrist and hand movement.
Okay.
What about arthritis? Is that something we commonly see as a late complication of distal radius fractures?
Unfortunately, yes, arthritis can develop in the wrist joint, especially if there's been articular damage or incongruity. This can lead to pain, stiffness, and decreased function.
So we've got a long list of potential complications, from early issues like infection and nerve injury to late problems like malunion, non-union chronic pain, tendon rupture, joint stiffness, and even arthritis. It sounds like managing these fractures is more complex than it might appear at first glance.
It is. Distal radius fractures can be deceptively complex, but with a thorough understanding of the anatomy, the different fracture patterns, and the potential complications, we can provide our patients with the best possible care and help them achieve optimal outcomes. Now, what I'd like to do next is shift gears a bit and talk about some specific areas related to distal radius fractures that you might want to explore further as you prepare for the FRCS exam. These are topics that often come up, and where having a deeper understanding can really give you an edge.
Sounds good. What are some of the areas that you think are particularly high yield for the exam?
Yeah, for the FRCS exam, they really test your ability to apply knowledge, not just regurgitate facts.
Right.
So as you review this material,
Yeah.
think about how you would approach a patient with a distal radius fracture in a real-world setting.
Okay, so taking that patient-centered approach is
Yeah.
key. What are some of the things that we need to consider from the patient's perspective?
First, think about their individual needs and concerns.
Mm-hmm.
What are their functional goals?
Right.
What are their expectations for recovery?
Yeah.
These factors should really guide your decision-making.
It's easy to get caught up in the technical details,
For sure.
but ultimately it's about helping that patient regain function and quality of life.
Exactly. A technically perfect reduction doesn't mean much if the patient can't use their hand properly.
Right.
So pay close attention to their range of motion, their grip strength, and their ability to perform activities of daily living.
And don't forget about the importance of a tailored rehabilitation program.
Absolutely. Early mobilization is key, but it needs to be individualized, based on the fracture pattern, the stability of the fixation, and the patient's progress.
Any other parting advice?
Remember, distal radius fractures is a constantly evolving field.
Yeah.
Stay curious, keep reading, learning, and pushing the boundaries of what's possible in hand surgery.
Great advice. So to recap for the FRCS exam, focus on applying your knowledge.
Yes.
Take a patient-centered approach. Prioritize functional outcomes and never stop learning.
That's a great summary.
All right, future FRCS surgeons, we've given you a comprehensive overview of distal radius fractures. Now go out there and rock that exam.